Hello, good afternoon, and a warm welcome to this session on BMJ Best Practice, our evidence-based knowledge and digital education tool. Kieran Walsh is my name. I'm Clinical Director at BMJ. I'm a geriatrician turned editor turned educator. Thank you very much to Health Education England, HEE, for making this the session available. We delivered it live a couple of days ago, but we know many of you, unfortunately, were too busy to be able to attend it live, so we're delighted to make this recording available as well. Please just wait a second while I share my screen and share slides now. And so here we are. This is what we're going to talk about, BMJ Best Practice, and this session will be aimed at primary care. And this is specifically what the agenda will be. There's going to be brief introduction or reintroduction to BMJ. Going to talk briefly about background to evidence-based medicine and clinical decision support. We're going to talk specifically about BMJ Best Practice, take a deep dive into it, including new additions and features of BMJ Best Practice like case reports. We'll do a live demo, and then we'll we did do a live Q&A, but we won't be doing a Q&A now. So to start off, an introduction to BMJ. BMJ is a global healthcare knowledge provider with the vision of helping to create a healthier world. That's our vision, and our mission is to share knowledge and expertise to improve healthcare outcomes. Now, we know that the M in BMJ stands for medical, British Medical Journal, but we want to reiterate the point that we're wider than just medical. We're keen that doctors use our resources, but also that nurses do so, and physician associates, and allied healthcare professionals, and indeed everybody who works within primary care. And so a little bit more about BMJ. We're best known for our flagship journal, The BMJ, but actually we do over 70 journals like Heart, Gut, and Thorax, but also non-clinical journals like BMJ Open Quality. We also do meetings like the BMJ Quality Forum, and we also do digital education such as BMJ Learning and point-of-care clinical decision support such as BMJ Best Practice. But no matter what we do, we're very much driven by our values, and our values are more than just words on a page. They're relevant very much to what we do at BMJ Best Practice. I won't read them all out, but ones that are particularly relevant are independent. Our content is independent of commercial interests. We are transparent. If there are any competing interests amongst contributors, peer reviewers, ourselves, we make them explicit. And we also try to be patient-centered. And I'll be talking a little bit later about the patient information leaflets on BMJ Best Practice. And lastly, of course, our last relevant value here is evidence-based. Of course, we try to make everything on BMJ Best Practice evidence-based, which leads us seamlessly on to a couple of slides on evidence-based medicine, because clinical decision support is about the implementation of evidence-based medicine. In 1972, Archie Cochrane pointed out the importance of testing the effectiveness of healthcare. So the concept has been around a while, but it was in 1992 that Gordon Guide first coined the phrase. And he spoke about the need for a shift from intuition and unsystematic clinical experience and pathophysiological rationale to scientific and clinically relevant research. And the definition has undergone various iterations down through the years. But we particularly like this graphical definition by Satterfield et al., who said that evidence-based medicine should be based on the best available evidence, but also on resources, including practitioner and professional expertise, and also on patient and population characteristics, needs, values, and preferences. And if you put all those together in the center, that should be evidence-based medicine. Unfortunately, there's too much emphasis on the best available research evidence, which is important, but will only work if you think about the professional and the patient as well. So we're trying to balance all three. Nonetheless, as soon as the term evidence-based medicine was coined, people were coming up with obstacles to its implementation. Here's one obstacle: information overload. There's too much to read and evaluate. Some might say evidence, evidence all around, but I can't find the evidence that I need. Another obstacle is the slow pace of implementation of the evidence. So on average, it takes 17 years for new clinical knowledge to become routine clinical practice. An example is thrombolysis and myocardial infarction, which was proven to be beneficial many years before it became routine practice everywhere. And there are multiple other problems with evidence-based medicine. Here's a list of such problems by a paper from Trish Greenhall et al., Evidence-Based Medicine, a Movement in Crisis. I won't read them all out, but the paper is available on the BMJ. They range from the evidence-based quality mark being misappropriated by vested interests, such as commercial interest, too much emphasis on statistically significant benefits and not enough on clinical benefits, and lack of shared decision making. And it's all these problems that we're trying to overcome with our clinical decision support resource, BMJ Best Practice. I should say at this stage that if you want the slides, I'll be sharing my email address at the very end. Please just send me an email. I'm very happy to share these slides if need be. So what's the answer to all these different problems? Increasingly, we think that learning knowledge is not the answer because no single person can keep up. And we think that the future will lie in having some core knowledge, but also learning knowledge searching skills and having 24/7 access to point of care clinical decision support tools via mobile devices, online and offline. And that's exactly what we've been trying to create with BMJ Best Practice, both website and app, clinical decision support that most importantly will work at the point of care. So BMJ Best Practice, really importantly, is a generalist point of care tool aimed at fully qualified GPs and those in training, but also all members of the interdisciplinary team, including nurses and physician associates. It's structured around the patient consultation with advice on diagnosis and management and follow-up. It's essentially a knowledge resource to help guide clinical practice. And really importantly, it's freely available if you work for the NHS in England. We're grateful to HEE, Health Education England, for funding it. And I'm now going to take you through how you can access it and create your own account. So first of all, go to this URL, number 1 there, then enter your Open Athens username and password to sign in. If you need help with your Open Athens account or setting up BMJ Best Practice, then go to your local library or you can go to this URL here. And then you should be able to get in. And once you're in, you'll be prompted to create a personal account. And you need to register to do that. That's free. But we encourage, most importantly, everybody to get a personal account. Why? Because you'll get access to the app as well, and also you'll be able to track and record your CME and CPD, continuing medical education, continuing professional development on the CME tracker on the site. You'll only be able to do that, get that personalized service, if you have a personal account. And once again, and I know I'm going on about this now, it is free to GPs, nurses, pharmacists, physician associates, all allied healthcare professionals, and trainees, but also managers and commissioners and social prescribers as well. If you work for NHS England, you'll have access to the content for free. Now, this is a clinical tool, so we increasingly present it through a clinical scenario to bring it to life and to look at it from a patient perspective, which is, as we said, often the missing link in evidence-based medicine. So here it is. Imagine we have a 70-year-old woman who comes to see you with a cough, fever, and loss of taste, unwell for a week, and tests confirm your clinical suspicion of mild COVID-19 infection. So far, so very straightforward. And you might ask yourself, well, how should I treat this patient? And first of all, you'll go to BMJ Best Practice and you'll be prompted, this is your patient of mild, moderate, severe, etc. And you'll click on mild and you'll get initial treatment advice. But underneath each one, even for this simple scenario of mild COVID-19, there's quite a lot of detail underneath it. And you got to travel back in time to spring 2020 and remember that at that stage, you didn't know much about COVID-19. And so you really needed this advice. When I was a junior doctor, which is a few years ago now, you could still get away with learning things by heart, but no longer, because of the detail, because of the volume, and also because of the pace of change. And yet there's more. If you need to prescribe, then there's links to relevant formularies, with of course the British National Formulary and the BNFC, British National Formulary for Children, available. Seamless links and granular links to get exactly the part of the BNF that you need. But what if your patient has long COVID? They might need non-drug treatments. And here I'm showing an infographic of management of long COVID in primary care. And I put this in partly because of the importance of non-drug treatments, but also because our users really like infographics, and we're doing an increasing number of them. Back to the patient, of course, the patient might want and need information. So you can find a patient information leaflet on BMJ Best Practice linked to the professional resource, which is evidence-based, which is continually updated, and which parallels the professional content. So ultimately, you get a patient outcome of a patient improved and well once again. But it's not straightforward to deliver that. To deliver evidence-based care, you need support. You need updated guidance, and this guidance was changing every few days at one stage in 2020. And you also need actionable recommendations, which you can put into practice. And I guess what I'm trying to show is the enormous complexity of doing this for just one condition. And this is, I think, evidence once again that clinicians need clinical decision support. And what do they need within clinical decision support? Well, ultimately, an answer to their clinical question, but not just any answer. They need an answer that's focused on what's important to them. And what's important to our users is a number of things. First of all, speed. They want answers quickly, within seconds. They want practical, actionable information for use at the point of care. They want to be reassured that the content is evidence-based and continually updated. And they're also accessible anytime, any place, anywhere, on a mobile, on an app, increasingly integrated into the electronic healthcare record, and more about that in a second. And just to talk through some of these things in turn. First of all, they need to be sure that they will get an answer. And we've got a comprehensive content set on BMJ Best Practice, over 1,000 topics covering 32 specialties. The content is continuously updated. We used to update the content annually. We changed that to a continuous process of updating a few years ago now. The search and browse is built so that users can get answers that they need quickly, i.e. within seconds. And the content is laid out so that the structure follows the clinical workflow without interruption, from diagnosis to management to follow-up. When something important changes, we'll put that on the launch page of the topic, but only when it's something important and practical that will change your practice. And the content is available in a range of different formats, from mobile to app, but also you can create a PDF of the content and print it out as well if you wish to. And the treatment algorithms on BMJ Best Practice are increasingly popular and important. And here's one example treatment algorithm for COPD. And as you can see, it takes you through to decide whether your patient has an acute exacerbation or ongoing symptoms. And then what you might want to offer as first line, what you might need to add in as additional treatment, what you might need to add as second line treatment, etc., etc. And this is important because then you get recommendations that are relevant to the person in front of you. And so it's a step towards more personalization of the evidence base. The content is continually updated. Here's just some examples of content that was updated in one day a few days ago. So it's continuous updating. When something important changes and you've looked at it in the past, we'll send you a notification. So for example, if something important changes in gout and you've looked at it in the past, we'll send you a simple notification. Not too frequently, at most every few weeks, and only when it's relevant to you. We have a range of different resources on the site, including calculators, patient information leaflets, other things. The important thing is to have them all in one place, because that's what our users tell us that they want, so that you don't have to log out of one system and log into another system to get the resources that you need, so that you can, in this case, perform calculations without disturbing your workflow. And there's a range of different calculators on the site, many of which are relevant to primary care, from simple BMI calculators through to the stroke risk calculator, i.e. calculation of stroke risk in patients with atrial fibrillation. We also have patient information leaflets on the site, which are written in layperson's language, aimed at a reading age of 12. And they speak to, once again, the patient's role in evidence-based medicine. They're accredited by the information standard, and they result in the patient and professional singing from the same hymn sheet, because the patient information leaflets are updated and evidence-based in line with the professional content. So essentially, the patient and professional are looking at the same content, just simply in different formats. And we have over 500 patient information leaflets today. We also have a range of procedural videos on the site as well, because most of BMJ Best Practice is about medical knowledge, applied knowledge, but you need more than just knowledge. You also need procedural skills, communication skills, team working skills. And so we've created videos on things like how to perform a peak expiratory flow rate, how to use certain inhalers, um, what certain heart sounds and breath sounds sound like, but also on communication skills. Many of the procedural videos are animated and they're all short because we know people have short attention spans when online. The site is increasingly image and multimedia rich, and it covers a range of specialties where multimedia is important, from dermatology, ophthalmology, ENT, cardiology. We only use clinical images when they really add value to the healthcare professional. An important new addition to BMJ Best Practice are case reports. So we've recently added case reports of rare diseases or sometimes uncommon presentations of more common diseases to BMJ Best Practice. This has enabled us to increase the content base from 1,000 core topics. We have added 5,000 case reports, which have been published in the past 5 years. And they're selected for the fact that they're important scientifically, but also because they're important from a medical education perspective. And so clinicians get quick access to this guidance on rare diseases and rare presentations of more common diseases as well. Sometimes people ask us, well, what's underneath BMJ Best Practice? What's behind the guidance? And most people use BMJ Best Practice just to get a quick answer to their clinical question, which we're delighted to provide them with. But if you are curious, you can click through and find that the content is based on Cochrane clinical answers, which in turn is based on Cochrane reviews. It's also based on the best available systematic reviews, meta-analysis, and randomized controlled trials as well, and also best of breed national or international clinical guidelines, like NICE guidelines, like, say, the GOLD guidelines in COPD. And you can, if you wish to, drill down to find out, well, exactly what the recommendations mean in terms of evidence-based medicine, i.e. using the PICO format. So we won't just say, oh, antibiotics work for patients with sinusitis. Rather, we'll say, in this population of adults with acute sinusitis, intervention A, short course antibiotics, as compared to intervention B, long course antibiotics, result in the following outcomes. And here is the effectiveness of that. And here is the confidence in the evidence, how strong the evidence is. When you create a personal account, which once again we encourage everybody to do, you'll be able to track and record your activity and your searches on the site and be able to print out at the end of the month everything that you've done on the site. And you can also, importantly, add reflections to your certificate and also add a note on how your searches have impacted on your learning and your clinical practice, which are both really important for appraisals. Another new resource we've added to BMJ Best Practice recently is the local guidance tool. We know many organisations in primary care throughout the NHS have their own local guidance and local protocols. And so we can enable institutions to upload or create links to their own local guidance or protocols to sit alongside the national or international guidance from BMJ Best Practice. Of course, as you'd expect, the content is also available via mobile, regardless of the type of mobile that you have. And also, there's an app, and it has everything you'd expect from an app with quick download time, i.e., within seconds, using minimal storage on your phone. And also, importantly, it's available offline. And you get all the features offline as you do on the live website. Increasingly, we've seen interest from institutions who are keen that BMJ Best Practice content is integrated into the electronic healthcare record or electronic patient record. And we can do different levels of integration today, from a simple link through to search widget, through to HL7 info button standard, through to deeper levels of API integration. And this enables better access. It enables you to access the content without interrupting the clinical workflow, to access it quickly and within seconds. So if you or your institution might be interested in discussing how we might do this, please do drop us a line. I'll show my email at the end of the presentation. And we have now put the building blocks and the foundation in place where we can do this really quite quickly. Another new resource is that we have guidelines that enable the management of not just the acute condition, but also related COVID-related comorbidities, in this case, in the case of COVID-19, an acute exacerbation of COPD, and these are freely available. So do please have a look at that also if you get a chance. I'll come back and do a demo in a second, but I always like to start and end with the values because the values of editorial independence and transparency are vitally important, but also that we're patient-centric and also focused on your needs. And everything that I've showed you today has been built because users, healthcare professionals have told us that they need to have it to help them practice. So if you have ideas, please do let us know. A short call out to the BMJ Best Practice Clinical Champion Scheme. Clinical champions are doctors or other healthcare professionals who spread the word about the resource locally and also help us to improve the resource. And we also offer them learning and education on the latest in evidence-based medicine and using clinical decision support to drive quality improvement, but also digital health. And some clinical champions have really stretched themselves in the role and led on digital education projects and also quality improvement projects locally, which we've been really delighted about. So if you or one of your colleagues or juniors might be interested in finding out more about the clinical champion role, please do let us know. And importantly, here's my email address. I'll leave it up there for a second. Please do get in touch if you want to find out more about any of the things I've been talking about. I'm just going to stop sharing screen for a second, and I'm going to now share. Going to do a live demo of the site. Be very quick. I'm just going to present again now. So you should once again be able to see my screen. And here's BMJ Best Practice with all these resources I've been talking about, from the clinical content through to calculators, patient information leaflets, procedural videos, case reports. But let's just look at one condition. COVID-19 is probably still a good one to look at. And as you can see, it follows the clinical workflow with advice and diagnosis, management, and follow-up. And we've got content here on epidemiology, which normally I wouldn't show, but because it's COVID, it's important to keep it continually updated. Etiology also often I wouldn't show, but there's so many myths about COVID, we feel it's really important to have a clear outline of its causation. We also include typical case histories of how typical patients might present. And I'm not going to click on everything, but just jumping on to the history and examination, what the typical signs, symptoms and signs are, and you can expand these and shrink them again. And also investigations, which you might request from first line, second line, etc., etc. Once again, you can expand these. And also differential diagnosis. So you can find out what else could it be besides COVID-19. And as you can see, community-acquired pneumonia is at the top. And also you can, if you wish to, click through to the full topic on community-acquired pneumonia, but I won't do that today. Just one last thing to click on, which is the treatment algorithm. And this will show you once again what's treatment options for very mild, moderate, severe COVID-19, but you can click through to mild and you can get further detail on any of these pieces of guidance. So once again, I'm going to stop sharing and I'm going to show my email address one last time now on the slides here. Should be able to see my email address. So once again, really encourage you to get in touch if you have any suggestions, feedback, thoughts of what else we should be doing with BMJ Best Practice and how we can further spread the word. Or if you're interested in integration, or if you're interested in the clinical champion role, we'd really love to hear from you. So once again, thank you very much for listening and we hope you found this helpful. Please do get in touch if you wish to find out more. Thank you.